Hey guys, welcome back to my channel, The ENT Resident. Today I'll be finishing the topic of tympanoplasty. In my previous video, I have discussed what are the different definitions involved in tympanoplasty, a little bit about the physiology behind tympanic membrane perforation, the different types of tympanoplasty, what are the grafts we use, the indications, contraindications, prerequisites for surgery, what are the goals of tympanoplasty, and we ended our preoperative evaluation of the patients. Now, in today's video, we will be talking about the different surgical approaches we can take, what anesthesia is given to the patient, what are the different grafting techniques like underlay and overlay, what are the different steps in each of them, and how do you take postoperative care of the patient, and what are the complications that you face in tympanoplasty. So let's get started. First, we'll be talking about the different surgical approaches to a ear surgery. There are three different approaches that you can take. The first one is an endomeatal or a transcanal approach, where you approach through the external auditory canal. Here, the incision that is taken is known as Rosen's incision. And the primary important part over here is that this surgical approach requires that the meatus has to be wide enough for it to work. So the Rosen's incision can be divided into two parts. First of all is a First part is a small vertical incision that you give at 12 o'clock position near the annulus. And second is a curvilinear incision that you can see in the image over here, which starts at 6 o'clock to meet the first incision in the posterior superior region of the canal, 5 to 7 millimeter away from the annulus. This is how the Rosen's incision is given. And after giving the incision, the posterior meatal canal skin is raised in continuity with the tympanic membrane after dislocating the annulus from the sulcus. Indication of this approach is usually small posterior perforations when the size of the canal is large enough. And advantages of this is that the inconvenience of mastoid dressing could be avoided, like that which is done in cases of postauricular incisions. And secondly, here you can avoid the postauricular incision. This is cosmetically better as you are approaching through the external auditory canal. Second, we'll talk about the end oral approach. End oral approach is done with the help of Lempert's incision. And Lempert's incision has two parts. The first part, which is the Lempert's 1 incision, the first image over here that you see, here we first give a semicircular incision made from 12 o'clock to 6 o'clock position in the posterior meatal wall at the bony cartilaginous junction. So the Lempert's one is first of all a semicircular incision. We are going from 12 o'clock over here to 6 o'clock at the bony cartilaginous junction. Second, Lempert's 2 is the second incision, which starts from where the first incision has been given at 12 o'clock, right over here, you can see. And this passes upwards in a curvilinear fashion between the tragus and the crus of helix. It passes through an area which is known as the incisura terminalis, and this area is devoid of any cartilage, so this incision does not involve cutting through the cartilage. The indications of this approach is usually a moderate to a large central perforation, and this is also easy to do in anterior perforations because in this approach we get a better view of the anterior part of the tympanic membrane. Last of all is the post-oral approach, and in this approach we do an incision which is known as the Weil's incision. Here, the incision starts at the highest point of attachment of the pinna, and this follows the curve at the retroauricular groove lying 1 centimeter behind it, and this ends at the mastoid tip. This is how the Weil's incision looks like. The part which is marked A, this is post-oral Weil's incision. However, we need to make a slight change in case of infants and children up to 2 years of age. In these cases, what happens is the mastoid process is not fully developed and the facial nerve lies exposed near its exit. And so as to not to cause injury to the facial nerve, The incision is slightly modified where it is slanted posteriorly, avoiding the lower part of the mastoid. The, the one marked in C, this is the incision that is given in infants and children below 2 years of age so as to not injure the facial nerve. Now, the indications of post-oral approaches are narrow canals with poor visibility of anterior margin of perforation. Second, in medium to large anterior and inferior perforations, and in total perforations. So, these are the three surgical approaches to any ear case that you come across. Now, let's talk about what anesthesia will we give to tympanoplasty patients. Now, usually these cases are done under local anesthesia, but in children and anxious adults, you can give them general anesthesia. And the local anesthesia, the infiltration involves 1% xylocaine with 1 in 1 lakh adrenaline. Next, now that we know what anesthesia has been given to the patient, next we need to know how will we position the patient. The patient is placed close to the edge of the table in order to prevent the surgeon from hyperextending their arms. The head is turned 120 degrees away from the surgeon, and this is supported with a folded towel between the table and the contralateral cheek. So the ear undergoing surgery is facing up. And when the patient is rotated towards the surgeon, this allows better visualization of the posterior area of the surgical field, and rotating the patient away from the surgeon improves the visualization of anterior surgical field. So now that we have positioned the patient, there are a few things we need to know about hemostasis. Now, hemostasis is very important to attain in any otological surgeries, and there are certain things that you need to follow for it. First of all, you need to discontinue aspirin and any other anti inflammatory medications 10 days prior to surgery. Second, discontinuation of anticoagulants if the patient is if the patient is that of a heart disease patient or a stroke patient. You have to discontinue their anticoagulants after prior clearance from their primary care physician. Third, injection of post-auricular incision site and the ear canal with 2% lignocaine with 1 in 1 lakh epinephrine at least 10 minutes prior to making incision. This will help you in attaining a bloodless field during surgery. Fourth, availability of otologic electromicrobipolar and conventional cautery. Fifth, using gel foam soaked in undiluted epinephrine to attain a dry surgical field. Why epinephrine? Because this acts as a vasoconstrictor and reduces the blood loss. Last of all, frequent irrigation of the surgical area with saline solution will help you in keeping your surgical field clear. So these are some things you should remember to attain good hemostasis in your surgeries. Next, coming to prophylactic antibiotics. Do you think prophylactic antibiotics is required in every tympanoplasty case? Well, in uncomplicated cases, the ones which are coming to you with dry ear, dry central perforation, you do not need to give any prophylactic antibiotics. However, if the patient has come to you with a draining ear, antimicrobial coverage is recommended prior to surgery. So, next, let's move on. How are we going to prepare the surgical area? So 2 to 3 centimeter area of hair above and behind the auricle is shaved and it is rubbed with an alcohol solution. Why is this area chosen? Because this is where you harvest your temporalis fascia graft from. And since it is the most common graft material used, this is what we usually do. Drapes are placed on the skin to keep the hair away from the surgical area. Post-auricular area is injected with xylocaine with 1 in 1 lakh epinephrine, and the surgical area is cleaned with iodine and patient is draped. Now, coming to the most important part. There are two different tympanoplasty grafting techniques that you need to know. One is called underlay and the second one is overlay. The difference between them is that in underlay technique, the graft is placed medial to the tympanic membrane remnant or the annulus and the manubrium of the malleus. If you see in the image over here, this thing over here, let me use another color. This over here is the anterior annulus. and the graft is placed medial to it, medial to the annulus as well as medial to the manubrium of malleus. However, in overlay technique, the graft is placed lateral to the tympanic membrane remnant or the annulus, but medial to the manubrium of malleus. So you can see over here, this is the annulus. The graft is placed lateral to the annulus but medial to the manubrium of malleus. Now, each of these technique has its own advantages and disadvantages. So, the underlay technique, the advantage here is that it has a good graft stability. There is less chances of blunting or lateralization. It is much easier to perform compared to overlay technique. And adhesions in middle ear by previous surgery can be easily removed here. However, this also comes with its own disadvantages, like underlay is not ideal for large anterior perforations. You may need to do a canaloplasty for access, improved access. There can be a medial prolapse of the graft, and there can also be a retraction of the anterior edge of the membrane. So these are the advantages and disadvantages of the underlay technique of tympanoplasty. Coming to overlay technique, the advantages of doing an overlay technique where you put the graft lateral to the annulus and but medial to manubrium of malleus, that it is good for anterior or subtotal perforations, and it has a better visualization and coverage of the anterior margin of the tympanic membrane. The disadvantages of overlay techniques are there is a higher incidence of blunting of anterior sulcus, graft lateralization, and this can lead to a significant conductive hearing loss. There can also be formation of epithelial pearls from a failure to completely remove squamous epithelium of ear canal or tympanic membrane remnant. There can be delayed healing of the patient. This can occur because of completely removing and repositioning the skin of the ear canal. And on repositioning of the skin of ear canal, the areas which is devoid of epithelium may develop, and this can contribute to formation of granulation tissue and delayed healing. So these are all the advantages and disadvantages of both the techniques. Now let's talk about the steps of surgery in each of them. First, let's talk about the underlay technique. So in underlay technique, first after you have prepared and draped the ear, the external auditory canal is injected with 2% lignocaine with 1 in 1 lakh epinephrine to achieve hemostasis. Then, as seen in the image over here, a vascular strip incision is given just lateral to the tympanic annulus in the ear canal to elevate the tympanomeatal flap. So you give a vascular strip incision to elevate the tympanomeatal flap. Next, a post-auricular incision, as seen over here, is given approximately 5 mm behind the post-auricular sulcus, and bleeding is controlled with electrocautery. By grasping the auricle firmly and you pull it forward and outward, you first identify the loose areolar tissue in the vascular plane overlying the temporalis fascia. And after you have identified this area, you first harvest the temporalis fascia graft. Next is you give a T-shaped incision. You can see in the image over here, the T-shaped incision is given in the mucoperiosteal tissue overlying the mastoid cortex with the horizontal component in the avascular plane of the linea temporalis. This is the horizontal part of the incision, and the vertical component of the incision given between midpoint of this horizontal incision and the mastoid tip. So a T-shaped incision is given. Then you raise the mucoperiosteal flaps posteriorly, anteriorly, and superiorly. And once you have raised the mucoperiosteal flaps, the vascular strip is elevated out of the ear canal and kept in place with the help of a self-retaining retractor, as you can see in the image over here. And a second self-retaining retractor is placed vertically between the temporalis fascia and the mastoid tip. This is the temporalis fascia and mastoid tip. The second self-retaining retractor is placed over here. So now you have prepared the surgical field. This will allow an excellent exposure of the ear canal, the tympanic membrane, and the middle ear from the postauricular region. In case you require a canaloplasty, if in case you see that the anterior sulcus visualization is very limited by an anterior wall bulge, in that case you have to perform a canaloplasty. But otherwise, the next step is the skin of the inferior ear canal is elevated. You can see in the image on the left side over here. The skin of the inferior ear canal is elevated to the fibrous annulus, hence developing an inferiorly based flap followed by elevation of a superior flap. After the flap elevation, you enter the middle ear, you check the status of the ossicular chain, and if there is any middle ear pathology, you remove that middle ear pathology. You can see in the image over here, this is the ossicular chain. You check the status of the ossicular chain, the mobility of it, and any diseased area is removed from the middle ear. The surgeon should be vigilant for any case of dehiscent or high jugular bulb, any exposed horizontal segment of facial nerve, dehiscent internal carotid artery to avoid any major complications. Now, upon removal of all of the disease completely, the middle ear gets packed with gel foam, absorbable gel foam. This image over here, you can see you're packing the ear with gel foam. After packing the middle ear with gel foam, here the temporalis fascia graft is placed medial to the tympanic membrane remnant, draping over the posterior canal wall. You can see over here, this is the handle of malleus and this is the annulus. The temporalis fascia graft is placed medial to it and it drapes over the posterior canal wall as seen over here. And then you place small pieces of gel foam over the graft to stabilize it, and the inferior and the superior flaps of canal wall skin that you had raised earlier, you replace them back to their original position as seen in the image over here. These are all replaced back, and then you fill the ear canal with gel foam. The postauricular incision is closed in 2 layers and a mastoid dressing is applied. So this is the technique that you use in case of underlay, where you place the tympanic membrane graft medial to the handle of malleus and the tympanic membrane remnant or the annulus. Next, let's discuss the overlay technique. Here, you expose the ear canal through a similar process like that discussed above in the underlay technique through a postauricular approach. A vascular strip is removed from the ear canal and it is kept folded in the postauricular area with the help of a self-retaining retractor. Same thing. Next, the part where it is different is the skin of the ear canal medial to the bony cartilaginous junction and squamous epithelial layer of the lateral aspect of tympanic membrane. These are completely removed and kept in saline solution for later. The tympanic annulus is left in place and you perform a canaloplasty in case it is needed. You remove any middle ear pathology as you notice there and you check for the ossicular chain status. The middle ear gets packed with gel foam and here you place the graft lateral to the tympanic annulus, however medial to the handle of the malleus to prevent any lateralization of the graft. So this is how it will differ in the overlay technique from underlay as we were discussing previously. Now, to accommodate proper placement medial to the manubrium of the malleus, a slit is made in the superior aspect of the graft. And the graft should be long enough so that it extends all over the posterior canal wall. To avoid, one of the major disadvantages of overlay technique is it leads to blunting of the anterior sulcus. So in this case, so as to avoid that, you have to avoid draping the flap over the anterior canal wall. Now, the epithelium of the squamous epithelial layer that you had removed earlier, it is placed in its original position, and then you do a gel foam packing in the anterior sulcus to avoid a dead space, and then the gel foam is also placed on the lateral aspect of the graft to stabilize it. The vascular strip is returned to its original position and the external artery canal gets filled with gel foam. You close the postauricular incision and apply the mastoid dressing. So these are the steps of the overlay technique. Now that we know the steps of the surgery, What do we do in the post-op care of the patient? Patient is usually discharged on the day of the surgery itself, or if in case of uncontrolled nausea or vomiting, you can discharge the patient the next day. Mastoid dressing gets removed after a week. The first visit that the patient makes to you is after 7 days of the surgery, when you remove the mastoid dressing and you also remove the sutures. And you also advise the patient to avoid any kind of nose blowing so that it does not displace the newly placed graft over the tympanic membrane. Oral antibiotics are given for patients with infected ears at the time of surgery. And the gel form that you placed in the external auditory canal, you should not disturb that for 3 to 4 weeks. And lastly, in about 6 to 8 weeks following surgery, you are going to notice hearing improvement in the patient. And about 4 to 6 months after the surgery, you should repeat a pure tone audiogram to see the improvement in hearing of the patient. This is about the post operative care of a tympanoplasty patient. Lastly, let's discuss what are complications seen in case of tympanoplasty. Now, complications can be divided into two. There can be early complications or late complications. First, let's talk about the early complications. First, early complication that you see is an intraoperative bleed. Now, this bleeding is mostly iatrogenic, and this can happen. There can be multiple reasons of it. The first one could be accidental injury of a highly placed jugular bulb during the exploration of the middle ear. But because jugular bulb is a low pressure structure, it is relatively easy to control such bleeds. You can just apply a piece of gel foam soaked in saline, and that can help you in controlling the bleeding. Secondly, there can be also a bleeding from internal carotid artery. If this bleeding happens, it is way more catastrophic than that of a jugular bulb bleed. A pulsating structure in the area of eustachian tube orifice is suggestive of an uncovered or an aberrant internal carotid artery. Next, the next injury that is very majorly seen is facial nerve injury. A facial nerve exposed in its tympanic segment is vulnerable to injury, especially if involved with cholesteatoma or granulation tissue. Facial nerve monitoring can actually help you in locating the facial nerve and confirm neural integrity. So, if the patient comes to you with a post operative facial paralysis, how you will manage it will depend on whether or not the nerve was positively identified during surgery. So, in case the nerve was identified and it was not injured during procedure, then in that case, patient is just follow up with serial nerve electroneurography. And majority of the cases, the paralysis resolves by itself without any need for surgical intervention. However, if during the surgery the nerve has not been identified and its integrity is questionable, then exploration should be performed as soon as possible. Third complication is a wound infection or perichondritis. These patients usually come to you with a pain, erythema, and swelling of the incision site or the auricle. And perichondritis can develop usually subsequent to the use of end oral incisions in the cartilaginous ear canal or after cartilage is harvested from the auricle for grafting. In these cases, how do you treat them? You give IV antibiotics covering Pseudomonas and gram-positive organisms, and incision and drainage is performed for cases with abscess formation. This is completely avoidable by following meticulous surgical technique with minimal tissue damage. Fourth complication is a wound hematoma. These hematomas can develop at donor site of the graft, usually the temporalis muscle area and the auricle. And usually the patient will present to you with severe pain and swelling within the first post-operative day. A good hemostasis, you can prevent this during surgery by performing good hemostasis. And in case a patient does come to you with a wound hematoma, you need to do an immediate opening of the incision and drainage. Next complication is a cauda tympani nerve injury. Now, if there is a cauda tympani nerve injury, it will lead to some altered taste sensations for the patient. And you will see that actually stretching of the nerve is associated with way more symptoms as compared to transection of the nerve. And in majority of these cases, there's not much you should do. It's usually very self-limiting and recovery occurs within several months. from surgery. Next is sensory neural hearing loss. This can occur secondary to a direct injury to stapes, which can result from a manipulation of the structure during removal of a disease. And other causes include labyrinthine fistula and acoustic trauma resulting from a contact of drill with ossicular chain. And the last early complication involves CSF leak, which can happen following a dural injury. And this can be controlled with a piece of fascia or temporalis muscle graft placed over the dural tear. So, these are the 7 early complications that you see in a patient with tympanoplasty. Next, let's move on to the late complications. The most common one is the failure of your surgery. Now, what could be the results? What could be the reasons for this? Persistent or recurrent perforation, graft lateralization, epithelial pore formation. All these cases would require a revision surgery again. And the common reasons for failure of tympanoplasty is poor eustachian tube function, inadequate visualization of the anterior sulcus, extensive tympanosclerosis of tympanic membrane remnant, inadequate anterior support of graft with gel foam, and recurrent or residual cholesteatoma. So, this is about tympanoplasty failure. Other than this, some other lesser important complications, lesser or rare complications are blunting of the anterior tympanomeatal angle, stenosis of external auditory canal, tympanic membrane retraction or atelectasis, meningitis, or granuloma formation. So, this is all about complications of tympanoplasty. And with this, we come to an end to tympanoplasty. If there's any other questions you have regarding this, please put them down in the comment section and I'll get back to you. Thank you.